Good evening, everyone. Myself, Dr. Ketki Ramtike, Executive Member, ISA-NCB and MOC for today's webinar. I welcome you all. As we are all aware, today's academic feast is on obstetrics critical care by ISA-NCB in association with Omega Hospital and Om Charitable Trust, Nagpur. Now I request our Honorary President, Rashmi Shingade Madam, to brief us about today's webinar.
Hello. Hello. Hello, am I audible?
Yes, you are audible, but there is some echo.
Yeah. Respected faculties for today's webinar on obstetric critical care, Chaitanya sir and Manisha Shembekar and Dr. Manokant. Respected chairpersons, Sahai ma'am and Harkare madam. Respected seniors, teachers and dear friends, a very good evening and a warm welcome from ISA Nagpur City. Obstetric critical care has been emerging as a specialty, a new discipline, and a combined and multidisciplinary approach from the obstetricians, the anesthesiologists, the intensive care, the intensivist, the pediatric intensivist is required. And a basic understanding of the basic principles of obstetric critical care, they are very important to assess the sick parturient and the successful management thereafter. So let's hear from the faculties, the expert in this field. And I once again welcome you all from on behalf of ISA Nagpur City. Over to Ketki.
Yes, thank you, madam. Today we are privileged to have Dr. Mrs. Bhavani Sahai madam and Dr. Smita Harkare madam as our chairpersons for today's session. Sahai madam, she is a senior anesthesiologist from 1964 batch. She has done her DA and MD from GMC Nagpur. She has worked in GMC Nagpur and GMC Aurangabad, then Prince Aga Khan Hospital, Dar es Salaam, Tanzania from 1976 to 1980. From 1980 to 85, she was working in Mai Durgiri Medical College and Teaching Hospital, Nigeria. Am I audible?
Yes.
Yes.
Since 1985 till now, madam is working as a private practitioner, and currently madam is a consultant anesthesiologist in Avanti Hospital, Nagpur. We welcome you, ma'am.
Thank you. Thank you, Ketki.
Dr. Smita Harkare madam, she is a senior consultant anesthesiologist at Orange City Hospital. She is catering to all types of patients from neonatal to geriatric group who come to this tertiary care center. Her main interest is in high-risk pregnancies and neonatal pediatric surgeries. She has presented papers in national conference as well as has many publications in PubMed. We welcome you, ma'am.
Thank you, Ketki.
So, our first faculty for today is Dr. Manisha Shembekar madam. She is a past president ISA-NCB, a very integral and active member in ISA-NCB. Madam is a consultant anesthesiologist, clinical embryologist, IVF consultant, and one of the directors of Omega Hospital, Nagpur. We welcome you, ma'am.
Thank you so much, Ketki.
Yes, ma'am. I now hand over this to you now. You can go ahead with your presentation.
So is my screen visible to you all?
Yes, ma'am.
Yes,
Yes,
it is
yes,
visible.
So, respected chairperson, Sahai madam, good evening. And it is so nice to have you as chairperson for my talk, a doyen herself in obstetric anesthesia. And Harkare madam, who has been catering to all these difficult cases since so many years. I'm so happy to have you as the chairpersons. Um, it's a proud privilege for me to be speaking in my own city branch in front of my own people, but let me tell you, it makes you nervous. So I'll be speaking on maternal critical care education need of the hour. Let me thank Rashmi and Devyani for giving me this excellent opportunity. I bring greetings from Omega Hospital. Uh, Pregnancy is becoming more complex because of increasing prevalence of comorbidities and advanced maternal age. Education is essential for recognizing risk factors, critical illness by using early warning scores. This was emphasized in this article by BJA. Sorry. So Indian statistics says that the institutional births have increased from 38% in the past to almost 84% in rural areas and 94% in urban areas. And maternal mortality has declined drastically up to 97 per 1 lakh live births till 2020, and which is a reduction by 70%. However, maternal morbidity and near miss, we do not have any sufficient data about this. So, achhe din are here, but we need better days than this. So, in this paper, they said that maternal near miss is an indicator for maternal health and maternal care, not only maternal mortality. So, knowledge deficit, communication lapses, poor resuscitation skills contribute to poor outcome. Now, what is maternal mortality rate? According to WHO, a maternal death is defined as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. It also measures the risk of women dying from pure peril causes as well. So anything related to pregnancy and occurring within 42 days is considered as maternal mortality or morbidity. So maternal mortality rate is an overall indicator of nation's health. If a mother dies or is incapacitated, the entire house suffers. This is the picture that we keep on exchanging on WhatsApp, and which is really the correct picture in our Indian homes. She is doing such a multitasking that it is said that 4 to 5 people are required to complete the work that she alone does in a household. So if a mother is incapacitated, the children are neglected. And if the neonate survives, then the mortality of the neonate also is a matter of concern. We have come a long way from 2014 to 2020. The data later on is still not available. Maternal mortality rate in Maharashtra is 38 per 1 lakh live births but we still have a long way to go. We are second only to Kerala, which is much less, that is 19 per lakh live births. However, we still need to pat our back, but we need to do more in this area. Now, if we compare the Western world and prominent countries like Australia and New Zealand, we find that maternal mortality in the US is 17.4, which is much more than the other countries that they have studies. That is New Zealand, Australia, UK 6.5, France is 8.7, and this is mostly because of the racial differences that we have. So I must say that Kerala has come very near to the statistics of United States of America. This is a UK data. Why do we need a dedicated obstetric ICU? They say that 2.24 women in 1,000 require critical care. 21% of the women who are admitted are pregnant while they're admitted, while rest are admitted in the post-natal phase. So 46% of them are admitted on the day of birth, while 23% within a week of birth. So 46% mostly are because of the hemorrhage. The embrace emphasizes the need for early referral, multidisciplinary approach, and equal access to all. So this is a pyramid where we see that the maternal mortality is just the tip of the iceberg. Rest all are the maternal near miss situations like organ dysfunction, organ failure, which we do not even consider. The patient may survive, but she may be incapacitated and not living her fullest. So this is what we need to curb. So what is maternal near miss? Woman who survives life-threatening condition due to pregnancy, childbirth, abortion within 42 days of termination of pregnancy, irrespective of medical or surgical interventions. So near miss analysis indicates the quality of healthcare that our mothers are getting. There is a need for development of an effective audit system for that, and early detection and corrective action is the key. I could come across only one paper. This was studied in a medical college Indore, where incidence of maternal near miss and mortality cases were studied. Out of 4,786 deliveries, 15 deaths were reported and 74 near miss events where they came across so many near miss events. So this is one area which needs to be looked into. So they have, NHS has come with a modified early obstetric warning sign, that is MUOS, and it is really very helpful. They look into the physical parameters and note them down: respiratory rate, oxygen saturation, temperature, systolic and diastolic blood pressure, heart rate, level of consciousness. This is the general early warning scoring. However, for the parturient, they have added discharge, that is lochia, whether it is healthy or not, and proteinuria. So if you plot the parameters on this graph, then on this chart, then you come to know whether the parturient is doing well, that is, she is in the green pathway, or she needs some special care, which is the amber pathway, or she has deteriorated, that is the red pathway. The score of 5 to 6 is medium risk, and score of more than 7 suggests high risk. So education of caregivers, that is a nursing staff who looks after them in the wards, is the key to reduce these morbidities. So because writing down leads to mental clarity rather than clutter. This was a study done in critically ill obstetric patients in an American hospital and compared with an Indian public hospital. So there was a comparison of case mix, organ dysfunction, intensive care requirements, and outcomes. This is a very clear study comparing the American as well as the Indian scenarios. And what was the result? The maternal mortality was 2.3% in US versus 25% in the Indian hospitals, which is more than 10 times. Fetal mortality was 13% versus 51%. And inadequate prenatal care, delay in hospitalization, and when the patient was brought to the hospital, the illness was very severe. So severity of illness was seen, the difference was seen in these parameters. So they say that the staff education at the primary level is very important. Now, this is one more paper where implementation and efficacy of saving mother score in predicting maternal and morbidity and improving maternal fetal outcome was done. It was published in IJA. So 40 to 50% of maternal deaths are due to delay in recognition, diagnosis, and treatment. 82% deaths are due to obstetric causes in India. 2/3 are due to late referrals. And this study says that maternal morbidity significantly reduced in the group where the saving mother score was implemented. So it was only 21% as against 60% where it was not implemented. So these were the parameters and the cases that were studied. And they came to the conclusion that these morbidities are really preventable if you diligently look and monitor them. So what is required is triaging. Level 0 is normal ward care. Level 1, where there is risk of deterioration and the patient needs observation. For example, a case of preeclampsia, where you need to monitor her blood pressure every 2 hours. And if it is not responding to medicines, then you may have to step up the medicines. Level 2 needs invasive monitoring with one failing organ. And level 3 and 4 needs high-level critical care. So, Laksh is a government of India initiative. It is labor room quality improvement initiative, which was started in 2017. It has said that robust training of midwives to recognize early warning signs should be done. Staff should be skilled in monitoring of vital signs, recognize deteriorating health, and timely action should be taken. And skill of a team has impact on the general outcome of the mother as well as the baby. And the Manyata is a Foxy initiative which is adopted by Government of Maharashtra, where the staff is trained about how to manage these patients, how to monitor them. So I'm glad to share here that Omega Hospital is a center for skill enhancement for Lakshya and Manyata. Among the, I think it is only one in Central India. So 1 to 3% of pregnant patients require critical care support, which is not a large number. Those patients who come antenatally usually require respiratory support, and postnatally usually require circulatory support because of the PPH. Now, intensivists have anxiety when confronted with a pregnant patient because there are pregnancy-specific conditions which one does not encounter very often, and altered maternal physiology is a matter of concern. There are concerns about drug therapy, which should be given and which is contraindicated, and of course, the radiological imaging that we are always scared about. So, what you require is a dedicated obstetric ICU. And let me add that women who are unwell during pregnancy and childbirth deteriorate abruptly after a period of physiological compensation, because the physiological changes of pregnancy give them that extra margin, and then you feel that she is getting better, but then after compensating, she just collapses. The common causes of ICU admissions are sepsis and tropical diseases, hypertensive disorders, and hemorrhage. Susceptible population is older age group. More and more patients are coming after 35 and take because they get late marriages or take some treatments and come later. Obesity, BMI more than 35, and women who underwent fertility treatment like IVF pregnancy itself is a complicating factor. So as we all know, hemorrhage is the most common cause of maternal morbidity and mortality. 30% of maternal deaths are due to hemorrhage. We all know about the 4 T's, that is stone, tissue, trauma, and thrombus. Shock index is one bedside tool where we can assess the severity of the hemorrhage. Coagulopathy sets in early, and transfusion triggers should be activated as early as possible rather than waiting and watching. So a word about obstetric shock index. It is the heart rate divided by the systolic blood pressure. Normal range is 0.5 to 0.7. More than 0.9. If it is more than 0.9, referral to tertiary hospital is required. 1.4, referral to critical care unit is required. And if it goes beyond 1.7, then there is a high risk of adverse event and you may lose the patient. Another common causes hypertensive disorders, preeclampsia with severe features, BP 160 over 110, proteinuria more than 5 grams in 24 hours, cerebral irritation, epigastric pain, and pulmonary edema. Very rapidly progress if we do not control it in time, and eclampsia ensues. HELP and acute fatty liver of pregnancy are the later complications. Now, amniotic fluid embolism, although rare, can be fatal. It occurs within 24 hours of delivery because of the hypoxic respiratory failure. The coagulopathy ensues, there is multi-organ failure and cardiac arrest, and it is more often than not fatal, and the diagnosis is mostly by exclusion. Now, sepsis is one area where we lack, especially from the peripheries, the patients are referred in a very bad state, and 15% of the maternal deaths are said to be because of sepsis. So we should follow surviving sepsis guidelines. Crystalloids for fluid resuscitation is a must. Vasopressors should be initiated early. Norepinephrine is a drug of choice. Broad spectrum antibiotics to be continued for 7 to 10 days. And de-escalation in these patients is difficult as infections are polymicrobial and we just cannot know what is required. And patient presents with either hyperthermia or hypothermia there will be general discomfort and pain. Skin, there is pallor of the skin. Patient feels sleepy and confused, and there is a sinking feeling, and she may have shortness of breath. So there is a varied picture, and we have to just come to the diagnosis by looking at the signs. Now, what are the objectives of this critical care unit? Peripartum women should receive high quality critical care irrespective of their location, be it in an urban area or a rural area. To achieve this, critical care and maternity teams should work closely. Checklists and SOPs should be formulated. As far as possible, baby and mother should be kept together to minimize the psychological injury to the mother. So RCOA has come with these guidelines of enhanced maternity care. Appropriate equipment for neonatal resuscitation should be available. Obstetric team should visit at least once in 24 hours. Senior neonatologist should be available within 30 minutes if the need arises. Women requiring level 3 care to be shifted to appropriate critical care units with facilities and experienced personnel. And there should be a consultant who liaises between the critical care people and the obstetric services. So what about a childbirth in an ICU? It is not ideal and safe. It is because it is far from the maternity, or if any operative interventions are required. However, at term, delivery before transfer to a critical care unit is strongly recommended, and one should ascertain that the risk of PPH is low before you transfer the patient to a critical care unit. Now, in an emergency, it should be clearly mentioned the numbers of the obstetricians, neonatologists, and obstetric anesthesiologists, and to announce maternal prolapse, specific instructions should be given. So the patient should be assessed at least once daily. We should assess the uterus. This is done by the obstetric team. Assess the uterus, vaginal losses, and breasts. Uterus should be contracted and uterine height receded till umbilicus 1 hour postpartum, and foul-smelling lochia is a sign of infection. Now, just a word about airway guidelines in such patients. If you require a GA, I always assume that the patient is full stomach and give appropriate, take appropriate action for that, like H2 receptor antagonist, head up tilt, and cricoid pressure. We should keep in mind that desaturation sets in early because of the reduced FRC and increased oxygen consumption. So pre-oxygenation with 10 to 15 liters per minute is what is recommended now. And nowadays, high flow nasal oxygen is also available in most of the hospitals. And if that is so, we can go ahead with that. Modified RSI, rapid sequence induction should be done. Always have difficult intubation in mind, and appropriate equipment should be in place. Give a ramp up position for high BMI, and skilled help should be available. If the patient is having preeclampsia and uncontrolled BP, ensure that the BP is controlled before induction, and modified RSI should be done, and add opioid agent as a co-induction agent to further increase, prevent further increase in the blood pressure, which may lead to intracerebral hemorrhage as well. Keep in mind that patient may have laryngeal edema, and smaller endotracheal tubes should be available, and aortocaval compression should be avoided. So manual left uterine displacement is recommended. Now, what are the targets of ventilation? PaO2 should be more than 70 millimeters of mercury to allow placental oxygen transfer. PaCO2 should be 30 millimeters of mercury. Overventilation will cause decrease in the uterine flow, while hypercarbia will lead to fetal acidosis. So one has to keep a fine balance between the two. Delivery of fetus causes modest improvement in oxygenation. It is not a very dramatic improvement. So one has to just weigh the risks before you go for delivery of the baby. Caesarean section is said to have increased the risk to the mother. Prone position ventilation has been tried till 34 weeks of gestational age. It is said that it will relieve the aortocaval compression, and caudal excursion of the diaphragm improves. However, positioning is a challenge, of course, in such an advanced pregnancy. Now, circulatory support First and foremost is exclude aortocaval compression with 30 degrees left uterine displacement. Use judicious IV fluids to prevent pulmonary edema. Impaired tissue oxygen delivery is evident from arterial and venous lactate levels, so they should be done whenever the patient is in shock. Large bore IV cannula should be in place. Transfusion triggers as appropriate, and transthoracic echo is a good tool to assess the IVC and the requirement of further requirement of fluids. Now, what about the fetus? The fetus should be assessed twice daily. A poor cardiotocograph trace is indicative of compromised maternal physiology. So if you find an abnormal CTG, stop oxytocin drip if it is running. Give a lateral decubitus position, correct hypotension with fluid boluses and vasopressors, give oxygen and think, because if when the mother's physiology improves, the fetal physiology will also. So a word about nutrition. Avoid starvation. Enteral feeding is very well tolerated. Thromboembolism is a risk up till 6 weeks postpartum. So low molecular weight heparin should be given prophylactically. If it is contraindicated, then pneumatic compression devices should be used. Prokinetic agents like metoclopramide should be given to these patients. Now the drugs. All sedatives have depressant effects. Propofol and midazolam infusions are usually used. Dexmed can be used, but toxicity is reported. Paracetamol is safe, and NSAIDs should be avoided after 30 weeks to prevent premature closure of rectus arteriosus. Now, the imaging, which has this gray area, whether we should do it or not. So, CT pelvis leads to 10 to 15 grays of exposure to the mother. Chest radiograph delivers only 0.01 mgy. MRIs are safe throughout pregnancy and can be done whenever required. And focused point of care USG is safe and helpful. And this is the time when one should start learning and implementing them. And so if you need to do an X-ray, you can very well go ahead and do it, and shielding of the abdomen can be done. Now to step down, you can give proper handovers. Discharge summary should be complete. A case review should be done, and there is a need for staff debrief. We should go through the case and see whether there are any deficiencies and correct them without pointing fingers, so that we are better prepared to face another patient like this. Now, these patients require a lot of psychological support. Even a baby, if shifted to an ICU for a very simple reason, the mother keeps on crying all the time until she gets the baby back. So post-traumatic stress disorder is very common in these emotionally labile women. So separation from baby should be minimized. Baby pictures and diaries should be displayed so that she has that urge to get well soon and urge to live. Breastfeeding and skin-to-skin contact should be encouraged whenever possible. So to conclude, health of women during pregnancy, childbirth, and postnatal period should be a positive experience. Women and babies should reach their full potential of health and well-being. Thank you for patient listening. Thank you so much.
Thank you so much, ma'am, for that wonderful, elaborative, and informative presentation. I request our chairpersons if they would like to add on something or would like to say something.
So well said, Manisha. This was a wonderful speech on the this critical care, the need of the hour for the especially pregnant women and this thing. This has been studied that despite of so much medical advances, a significant number of the maternal deaths are related with the suboptimal care. And there's a story behind every maternal death and the life-threatening complications, and understanding the lessons to be learned can avoid such outcomes. So so really the need of the hour is obstetric critical care. So thank you very much for the wonderful presentation.
Thank you, ma'am.
Sahai ma'am would like to say something. Sahai ma'am, please unmute yourself. Ma'am, please unmute yourself.
Hello.
Yes, ma'am.
It was excellent presentation and really good work. But I felt very happy to know that your center patients can go with problems. But very sad thing, all these years we have been doing anesthesia practice, and every time the heart used to be in the mouth. Because any serious patient, if anything goes wrong, what shall we do? So now I'm very happy to know that now the patients can go to your hospital and good care will be taken by you and Chaitanya. Thank you so much. Excellent
you.
presentation.
Thank you so much.
Thank you, ma'am. We'll now move on to our next presentation. Dr. Chaitanya Shembekar, sir. He is a well-known name in the field of obstetrics. Sir acquired his surgical skills from national and international centers dedicated to this field. He is working, upgrading, and updating in the maternal and child care since 1997. We are extremely privileged to have you with us today, sir. Yes, sir. Please, you can go ahead with your presentation.
If you
please
stop,
unmute.
yeah,
Yes, sir.
once you stop sharing screen, I'll be able to start screen sharing. So thank you so much for this wonderful opportunity. Just give me 2 minutes so that I'll share my screen. And of course, it's a great honor for me to get this opportunity to speak in front of Department of Anesthesia and ISA Nagpur City branch. Yeah. So I guess my screen is now visible.
Yes,
Yes, sir.
Yes. It's visible and you're audible also.
Right. Thank you so much. At the outset, I would like to thank you all for this opportunity, and respected Sahai Madam and Harkare Madam and all the office bearers of ISN Nagpur City branch. Thank you very much for this wonderful opportunity, because it is always a pleasure to speak in front of you all anesthesia friends, and I am supposed to speak on the operational guidelines for obstetric ICUs and HDUs. I think this is something which has come up in the Government of India guidelines, and I'm going to discuss all these guidelines in the next 20 minutes. Now, I bring greetings from Omega Hospital, Nagpur, along with my directors. And of course, as Manisha has said, it's a phenomenal achievement where Bharat is now has achieved the MMR of 97 in 2020. And as we all know, Maharashtra is second in the list, but we have to work hard to cross whatever is expected from us, that is number one. And for that, we all are committed, and we all must work uh, in coordination, because we have public and private partnership. We have so many private hospitals where most of the obstetric work is done, and most of the deliveries they are the patients deliver in private setup. So we have to think of the private hospitals as well. We are very lucky to have my two friends, Dr. Poonam Verma and Dr. Surekha Thade, as contributors for this operational guidelines of Government of India. And we will just step by step try to understand how to set up an HDU. If you just look at the situation analysis in the medical colleges, you will find that there is always ICU which is run by a Department of Medicine or Department of Anesthesia. And these ICUs, anywhere you see, the situation is that they are full to capacity and there are no beds for obstetric patients. In most of the situations, critical care is offered to these patients, but the obstetric care is not offered. And therefore, what you get ultimately is suboptimal results and deaths. And therefore, you have to look into this matter seriously. And this is not a problem only in medical colleges, but also in private setups where there are so many ICUs. But even in private sectors, these ICUs do not cater to the obstetric patients. So with this concept of obstetric HDU and ICU came into existence, where you get a more robust system so that appropriate uh, and healthcare is given at all the levels, starting from the PHCs. So starting from the skilled birth attendant, the pyramid goes up to ICUs. And here, this is what they have added now, HDUs and ICUs, and these HDUs and ICUs are added to all the medical colleges and the district hospitals. So the rationale is to develop obstetric ICU and HDUs in all medical colleges and to have HDUs at district hospital levels. In addition to this, whenever we are discussing these national guidelines, we must start our thought process as to how to improve situation in private sectors as well. Because as I have said, most of us are working in private sectors, and therefore we have to think of the private sectors as well in addition to the government setups. So in the next 20 minutes, we'll be discussing about various issues like how to set up a ICU and HDU, what should be the plan, how to do the documentation, how to train the staff, and how to do the capacity building plan. What are the requirements as far as the drugs and the equipments are concerned? What is the role and responsibility of every person working in this HDU and ICU? What about the blood products and what about the diagnostic workup? What are the ethics of obstetric care? And finally, the problem of small nursing homes which are there in all the cities all over India. Can we have guidelines for these small nursing homes as well? So if you just talk about the numbers, it is very clear that if the number of deliveries are more than 1,000, then you require a full setup of 4 beds for ICU and 8 beds for HDU. This is what is the guideline says. But if the number of deliveries is between 500 to 1,000, here comes the problem, because here the workload is not much, and since the workload is not much, you may not get the patients for the ICU setup, and therefore it is said that they have concept of hybrid ICU has come up, where they have recommended 6 HDU beds and 2 beds for ICU. And if the delivery number is between 250 to 500, then you need to have 8 beds of HDU. And if the delivery number is less than 250, then 4-bedded HDU is sufficient. And another thing which is, you can say, food for thought, that can we have a 2 beds of HDU for small nursing homes where the number of beds is more than 30, but maybe less than 100, or up to 30 to 100 beds, small nursing homes, can we have 2-bedded HDU as well? So this is a food for thought. So what is the hybrid model? As I told you, this is the problem, you should say, something which happens everywhere, that there is an insufficient load of obstetric patients, and there is a wave. This is what we have experienced in last 27 years of my practice, that there is a wave, and when there is a wave of PPH, you start getting PPH almost every day, but then suddenly all is well, and then you are happy, you don't have to shift the patient, but then there is a wave of, say, severe preeclampsia. So these are the things where you need to have HDUs and ICUs which are functioning to the full capacity. And because of the insufficient load, you need to have a hybrid model where you can have 8 beds of HDU with 2 beds of ICU attached to these centers. And as I said, there is a mushrooming of ICUs in the private sectors. You see so many ICUs around. But can we have dedicated obstetric ICU along with HDU in the same setup where there is a general ICU? This is something which we should try to implement. If you have ICU and HDU for obstetric patients, dedicated ICU in the ICU setups which are all over city, we can have a better treatment options for these critically ill obstetric patients. As far as the staff is concerned, human resources is of course the first thing which you have to look into, and the consultants required for HDU is, of course, obstetrician. Obstetrician is always there, but it is said that you don't require an anesthetist for an obstetric HDU. Obstetric ICU, you require one anesthesiologist, medical officers, of course, one per shift, one nurse for two beds in HDU, and one nurse for one bed in ICU, M&E assistant for monitoring and evaluation, cleaning staff and guard. Here, I always feel that not only ICU but even HDU should have a anesthesiologist attached, because anesthesiologist is a key person in handling emergencies as far as the HDU is concerned. And HDU is the first step where there is a problem with single organ, maybe because of the PPH patient is having problem, or maybe because of severe preeclampsia and eclampsia patient is having problem. And here comes the role of anesthesiologist. Therefore, you need to have an anesthesiologist even for HDU, not only for ICUs. So these are the number of persons required: one for ICU, four medical officers for ICU and HDU, 20 to 16 staff nurses depending on the bed capacity, and one M&E assistant. Now, what are the roles and responsibilities? You need to have a person who is the head and of this unit, who is coordinating all the departments. So you require a medical superintendent for that. Then there is a head of the department of OBGY, who is actually a nodal officer, and the important stakeholder in this model is, of course, anesthesiologist and intensivist, and they are playing crucial role. And therefore, you require an anesthetist who is taking daily rounds. So you require a senior anesthetist who is taking daily rounds, and one anesthetist should be appointed as a responsible person who is directly a focal emergency point, who can be contacted anytime 24/7 if the emergency arises. And this coordination is must. So one person who is senior is supposed to look after the day-to-day working of the ICU, but one person who is looking after the emergencies. And this anesthetist is not only supposed to work for the HDU but and ICUs, but also is supposed to provide training to all the staff and the nurses and the medical officers working in the obstetric ICU. So the role of anesthetist is not only to take rounds to look after the patients, but also to train the obstetricians and the medical officers. This is the list of the diagnostic workup and the turnaround time. It is available online. So you should have all these investigations available 24/7 in your setup with the turnaround time depending on the situation. Then these are the investigations which you need to do. Then as far as the blood products is concerned, as we all know, whole blood is not preferred. So what you require is blood components. And it is said that running a component separation unit is, of course, a costly affair, but it is said that it is recommended and it should be available wherever it is possible. So as far as possible, you should have a blood component separation unit, because as we all know, the whole blood is not recommended. What you required is packed RBCs, yes, for HDUs and ICUs. Fresh frozen plasma, it is said that it is required for ICU, not for HDU. But I again feel that whenever you have a PPH, the first thing we do is we give 4 FFP along with the blood. So we require FFP in many situations. Random donor platelets, not in HDUs, but in ICUs. Single donor platelets to be procured whenever required. Cryoprecipitate, yes, for ICUs. Whole blood, of course, not recommended. And O negative PRPC for HDU as well as ICU. So these are the blood components which are required, and you must have the facility to get all these components whenever required. Now, as Manisha has already told you, there are guidelines for the care of the newborn during the mother stay in the ICU. And these are the guidelines which are to be followed very strictly, because there are emotions involved in the mother care. So decision to keep the newborn along with mother depends on the maternal condition. If the mother is critically ill, of course, you cannot keep the baby with the mother, and therefore you require relatives and pediatric units for that. Mother will require additional support for care of the newborn if they are in a position to give support. Then you have to have somebody who is attendant, who is helping mother for this. Then you always, and this is what we always tell patients, that encourage breastfeeding even if the patient is ill. If the patient is not critically ill, then breastfeeding should be encouraged. Rooming in should be done whenever possible, and pediatrician plays a very important role in this. The major component of the obstetric HDU and ICU is training. And this training is of two types. One is the obstetric training, and the second is critical care training. In obstetric training, all the nurses and all the medical officers should be well versed with the terminologies in obstetric which are used in obstetrics, and this is true with anesthetists as well. Then you should understand the basic drugs, the physiology and pathology of the pregnancy. You should know about the drugs and the injections which are required. You should learn about the obstetric emergencies. You should know about the operative obstetrics and the wound care. You should understand the importance of breastfeeding and should learn about the newborn care. As far as the critical care training is concerned, this is more critical and more crucial because everybody who is working in HDU should know everything about the critical care. And here comes the role of the setting up of the HDU unit, preparation of the crash cards, then how to operate different machines and equipments in HDU. This is something which should be taught. The interpretation of the monitoring is also important. You have monitors, but you should be able to interpret it. So all the nurses should be trained in that, to learn about the oxygen therapy, to learn about the blood transfusion practice, to assist in intubation. This is also important. If you have a good assistant, then intubation becomes easy. Nutrition and pain management should be done properly. CPR should be taught to the staff, and infection prevention and infection control policy of HDU should be learned by all the members who are working in the HDU. And here, this is the flow of training. As I have already told you, the anesthetist is the in charge of the training, and guidelines clearly mention that it is the role of anesthetist to train all the people working in the HDU, right from the nursing staff to M&E assistant. And the flow of training goes something like this. First, there is a theory part which should be taught, then skill stations, then you should give them hands-on learning and interactive sessions, then emergency drills and mannequins, and ultimately you should provide them certificate at the end of the training. Manisha has already told you about the Manyata certification course, which is available at Omega Hospital. Omega is CSC, that is Center for Skill Enhancement of Manyata. And we have in last 1 year trained 54 facilities in and around Nagpur. So all the anesthetist friends who are working with, who are attached to the maternity nursing homes and small nursing homes, I appeal them to ask your obstetrician to get their center certified, because this training is very important. All the nurses, all the staff, they will learn lot of things. आणि असं म्हणतात ना की सोनारानेच कान टोचावे. Similarly, if you train them, they get proper training. If an obstetrician who is managing the nursing home tries to teach this staff, they will never listen. But if you have a proper training and if you get a certificate, this is going to help them in a long way. And I must thank Foxy, Dr. Rishikesh P, Dr. Nandita Parshedkar, and Dr. Sabita Bharadwaj. They all have given us this opportunity, and it's a great honor for all of us because there are only 6 centers all over India, and Omega is one of the centers. So please, I appeal you all to get this your center certified, so that the nursing staff gets the advantage of this training and they will be able to manage the critically ill patients in a better way. These skill stations, you all know this, there are so many skill stations which are proposed by the Government of India guidelines: blood loss estimation station, eclampsia drill, infusion pump, oxygen therapy, intubation and airway management, ABG method and analysis, CPR, neonatal resuscitation station, ventilation station. And then you also should have mannequins which are required at skill station. They include childbirth simulator, adult advanced life support trainer, adult airway management trainer, and newborn resuscitation on trainer. These are the mannequins which are required. And then they have given clear-cut guidelines about how the training should go. And this training includes 31 days training for nursing staff, 20 days training for medical officers, and 10 days training for obstetricians. And this 10 days training is, they have given complete timetable of how to train the obstetrician in critical care in obstetrics. And this is based on the principles of train, teach, and transfer. And this is available online. So you can actually go through this uh, uh, timetable and you can follow this for training of the obstetricians. Then reporting is also very important, and there are many registers which are available online, and you all should look into this register and try to implement these registers in your day-to-day practice. And we all have NABH accreditation, and NABH has helped us in keeping the maintaining the records and data. And we at Omega have gone one step ahead, and we have internal auditors. They come every month at our center and they do audit of all the records which we are maintaining. And not only that, they call all our medical officers and they teach them how to maintain the records. So all these are available online, and you all must use these records so that you maintain the records in a proper way. There are list of equipments which are available online. You need to have, right from the ICU bed to the maternity cots to the infusion pumps to the ventilators, everything is required. How many units are required is given in details in this guidelines. Not only this, even list of drugs are available online. And all these things can be, you can refer all these guidelines so that your setup is well equipped to handle all the emergencies. The one more important point as far as the critical care is concerned is the ethics of critical care. And Professor Arul Kumaram has very nicely explained all these ethics as far as the obstetric critical care is concerned. They have given these levels of ICUs. We all know these levels of treatment, intensive care treatment. Level 0 is where the normal ward, no risk is involved. Level 1 is where the condition is deteriorating, so you have to shift the patient for observation. Level 2 is where intensive monitoring is required with a single failing system, except respiratory system. And level 3 is, of course, this is HDU, and ICU is, of course, where you require a advanced respiratory support. And they have given a very interesting chain response. And this is really interesting because here you will understand how the things actually happen in the obstetric setup. They have given a chain response of non-clinical staff, recorder, recognizer, primary responder, secondary responder, and tertiary responder. And you have to have a communication and handover amongst all these people involved in this chain response. So we'll try to understand this interesting chain response. First is alerter. Alerter, who is the alerter? Anybody who is around, maybe a relative or a visitor, or even the cleaning staff becomes plays a role of alerter. He alerts if something is going wrong in the ward. Then there is a recorder who actually is designated
दाल को वही रहने
work of measurement and recording the observation. This can be done by a midwife or assistant. He or she records the findings. And then there is a recognizer who interprets these findings. This can be done by either a nurse who is trained in interpretation, and also by a foundation doctor who knows how to interpret the various recordings which are available on the monitors. Then comes the role of primary responder. Primary responder actually is the person who goes beyond recording and tries to interpret the data and initiates the clinical management. He is actually responsible for starting the clinical management, that is starting the oxygen therapy or insertion of airway adjuvants and selection of drugs, etc. Then there is a secondary responder who is called when there is no response to the treatment. And these second responders can be a senior obstetrician or an anesthetist who is a second responder. And he is called whenever there is no response to the primary responder. The last but not the least is the tertiary responder. And this tertiary responder plays a very important role. And here comes the role of anesthetist. You all are anesthetist And if you are certified in training in obstetric anesthesia, you have to play the role of tertiary responder, who actually is responsible for advanced management. He is responsible for decision making, and he has access to information from the software in the hospital. So he is the boss. He will ultimately manage the patient, and the role of tertiary responder is always played by a anesthesiologist. So your role is really critical in all this obstetric HDU and ICU setups, and you are tertiary responder here. Obstetrician has no role to play. It is the role of anesthesiologist. There are some rules which you have to follow as far as transfer is concerned. When you are transferring a patient from from a maternity ward to a critical area, you have to follow some rules. Here you have to actually have the basic knowledge. Whenever anybody is running a maternity hospital, there should be a staff should get have a basic knowledge of resuscitation, stabilizing patient, and transferring patient to the critical care unit. And this is extremely important. So everybody has to have has this knowledge of resuscitation and stabilization of the patient. Then the transfer should be should take place with an appropriately trained practitioner. And this transfer clinician, you can have a designated transfer clinician, or anesthetist can play this role. And then the important fact is regarding positioning of the pregnant patient, and you should have idea about the positioning, because these are the patients who are having additional risk because of the aortocaval compression, and therefore positioning also is important. You should know how to do the positioning. Then whenever the patient is stabilized and you have to transfer the patient back to the maternity ward, you have to follow some rules. Here, one important point is quiet time, and this time is 10 p.m. to 7 a.m. So as far as possible, you should not transfer the patient back to the ward between 10 p.m. to 7 a.m. Then you should actually take the shared responsibility. So you have to have a shared responsibility between the ICU staff and the ward, so that there is a continuity of the care from critical care staff to the ward staff. And ultimately, you have to deliver, and you should stabilize the patient properly. There is something called as maternal and critical care area interface, and you should not forget. The patient will say, I am pregnant too. Please don't forget that I am also pregnant and I have a baby inside my womb, and I have you have to take care of my baby as well. So what happens mostly, that whenever a critical care consultant is managing a case of pregnancy with obstetric complications, you should not forget that she is pregnant, and therefore you should actually integrate the overall care plan in such a way that this pregnancy care is continued throughout the critical care. And this is something which is extremely important. We should keep this in mind, that patient is pregnant too, and you have to take care of her baby as well. सो दोस्तों, थोड़ा है, थोड़े की जरूरत है, जिंदगी फिर भी यहाँ खूबसूरत है. So we have so many things which we are already doing. We must do something more for our patients. And जाते जाते मैं कुछ बात कहना चाहूंगा regarding the unrecognized and unorganized private sectors and small nursing homes. So can we together, and this is for you, Rashmi, as a president of ISA Nagpur City branch, outgoing president, now you will be in the role of advisor. Can we have some guidelines so that we should actually work together, anesthesia and anesthetist and obstetrician, so that we frame some guidelines and try to help our friends in managing the emergencies which come as boat in blue. So you have so many standalone nursing homes which are still existing in Nagpur as well as all over India, and in fact they form the backbone of obstetric critical care and obstetric practice, and there is urgent need to regularize this sector. So I have some thought process in my mind, where can we categorize this patient into this nursing home into two units. One is a small nursing home where the number of beds is from maybe 4 6 to maximum 30 beds, and second is a mid-sized nursing homes where the bed capacity is from 30 to 100. So can we have a two-bedded HDU for 30 plus beds of a single specialty mother care or mother and child care? Because so many mother care hospitals are there all over India, and they are, you know, mid-sized hospitals, but they don't have the backup plan for obstetric HDU and ICU. So can we have two-bedded HDU for all these 30-bedded hospitals and 30 to 100-bed hospital? And can we have SOPs for small nursing homes, where what we can do is we can have area-wise critical care units, and we can recognize these centers, and we can officially allot such centers within the radius of 500 meters and upgrade them to handle obstetric emergencies. So all over city we have so many ICUs, so we can recognize these ICUs and upgrade these ICUs to handle obstetric emergencies. And we can have an obstetric anesthesiologist who is 24 by 7 on call along with the obstetrician, who can handle these emergencies within the radius of 500 meters. So all the small nursing homes will have a attachment to a ICU with a obstetric care facility. And this is a food for thought. We can start this as a pilot project in Nagpur, where we can have a SOPs and guidelines for private maternity nursing homes in Nagpur, because I know there are 500 plus small nursing homes in Nagpur, 550 members in NOGS. So we can recognize and recognize and make an action plan for the transfer of small nursing homes where the patient can be transferred to a particular unit. And for 30-bed hospital, we can plan two-bedded HDU with 24 by 7 on-call anesthetist and intensivist. So friends, it is ethical for us to respect you basic human rights, that is to preserve an individual's life and health, and to provide the care with dignity, self-respect, and confidentiality. It is also important that the patient and her relative get all the information and are involved in decision making. And the woman should be provided with the best of the care available with us, because pregnant mothers are young and are in their prime of life. Their health and life is compromised due to an obstetric or pre-existing medical complication. If the transient severe illness is overcome by providing critical care, then these mothers will continue to serve as the nucleus of the family and their society. So again, I must say that thoda hai aur thode ki zarurat hai. And I end with this famous, wonderful poem by Robert Frost. The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. Miles to go before I sleep. Special thanks to Dr. Rashmi Shingad and Dr. Devani Thakur for giving us this wonderful opportunity. आप सबका तहे दिल से शुक्रिया. Thank you very much.
Thank you, Chaitanya sir. It was an honor for us.
Thank you.
Your points are noted. Let's see what we can do. Actually, we had a meeting of all private practitioners in Nagpur, and we discussed about updating or upgrading the small nursing home, because whenever they go to the small nursing home, they have a lot of trouble because all the basic monitoring facilities are not available.
Not available.
Yeah, so we had a meeting twice this year also, and we are. It was not about only obstetrics, and it was in general for all the working conditions and the minimum standards of monitoring that are required in the nursing homes. So we are working on it, and I hope we come up with something with. And you have suggested very good points, and it was very well simplified from the 30-bedded hospital to the and this was a minimum requirement, and it can be done. But I feel it's not impossible, and even. And ISNCB has 650 plus members capacity here. We have enough of anesthetists all around, all the young lot and everyone. So I think it can be done. So let's see what we can do.
Yes.
That's a nice deliberation.
Thank you. Thank you.
Dr. Chaitanya.
Yes, ma'am.
Dr.
Okay, Smita, you.
Thank you very much. Such a nice presentation and so much wonderful suggestions for setting up of the high dependency units. So many hospitals are there who have the general wards, the deluxe ward, the CCUs, but no high dependency units. So that is the need of the hour. Secondly, the high dependency unit is a level of the care which lies in between general ward and the CCU, and this takes care of the patient who have the single organ disturbances or failure, you can call it. And this will help in recognizing the medical problems of the maternal patients, and speedily the treatment can be given and the life can be saved. So that is really the need of the hour, and we all are with you for that. Thank you very much.
Yeah, we'll do something for this
Yes.
noble cause. Yeah.
Yes, hi, ma'am.
Hello.
Yes,
Excellent presentation, Chaitanya.
Thank you, madam. Thank you
Knowledge,
so much.
and I feel it was full of knowledge and very good. And I feel you should have one more repetition of your talk sometime after, so that we assimilate more. It was
And we'll,
excellent and very happy to know that so many good things can be done. But I request dynamic people like you, Manisha, then our Rashmi, all of you together should do something for the city. And it will be really good for the patients. And we oldies, which we did not get, and we had to do practice with such difficulties, we'll be very
yes,
happy for the patient and for all of you. Excellent
we,
presentation. But I
madam, we will have.
request
Yes, ma'am.
you must have one more like this so that we assimilate
Yeah.
more in our brain. It was
Yeah,
excellent.
actually, we will have review meeting, madam, so that we can we'll
You
analyze
should.
what we have done. Next
Yes,
year, at
you
the same
should.
time, we'll have a review meeting.
You should have a review meeting. Okay. Okay. Thank you. Excellent.
Thank you, madam.
Thank you so much, sir, for that putting that vast and complex topic in such a simple way. Thank you so much, sir. Now moving on to our next presentation. So Dr. Manokant sir, he is a consultant anesthesiologist at Fernandez Hospital, Hyderabad. His area of interests are medical disorders complicating pregnancy and patient safety. Over to you, sir.
Good evening, everyone. Good evening, Chairperson, Dr. Babani Madam, and Dr. Madam, and my dear colleagues. It's a great honor and pleasure to be with you, and I thank you. I thank the ISC Nagpur City Branch for giving me this opportunity. Special thanks to Dr. Rashmi Madam, Dr. Kirti Madam, and Dr. Devi. So I'll be sharing my screen. And my topic for tonight is identifying the sick children. So it's kind of a summary of what Dr. Manisha and Dr. Chaitanya have already spoke about, and I'll add a few more things to that. Basically, I'll be touching upon the epidemiology and then primary and secondary survey, that is the clinical examination, and scoring systems that exist, and then some conclusions. Epidemiology, so we know who is a sick children. So they can be somebody with pre-existing medical condition or somebody with a bad obstetric history. And we also know that it can be tricky to identify who actually is sick, because normal pregnancy is more common. And usually these women develop complications unexpectedly. And then they require early identification and intervention to avoid any mortality or catastrophe. So in one of the studies, a review of ICU admissions looking at pregnant patients, 67% of the women or students who got admitted to the ICU did not have any past medical or obstetric history. And 40% of those women who got admitted to the ICU required ventilator support. 66% of these women were because of hypertensive disorders of pregnancy. And there were 3 maternal deaths. So imagine 3 women dying while they were completely normal when they got pregnant. So roughly, so this is the Western statistics. Again, about 0.05 to 1.7% of women who are pregnant may require ICU admission, and about 5% of women who are pregnant may require a HDU admission. So where do you find this? So these women you can see these sick women in the OP, in the emergency room, in the ultrasound department, or even in the ward. And then sometimes everything's fine, and suddenly a woman can get sick on the operation table, in the operation theater. And there can be sometimes dramatic deterioration in a woman who's already admitted. to the ICU. And why do we fail to recognize this? Because Dr. Manisha has already mentioned, they have enormous physiological reserves. So they tend to maintain them, compensate for a long time, and then they suddenly collapse. And because of the increased blood volume from the physiological changes. And then seeing a sick pregnant woman is a relatively rare event because most of the times pregnancy is assumed to be a natural process. And then there is the lack of clinical knowledge and skill when it comes to handling an obstetric sick woman because it involves both mother and baby. And then lack of simple scoring systems which can alert the healthcare staff early. So whose responsibility it is? It is everybody's responsible who's involved in the care, right from obstetric consultant to a resident, anesthesia person, trainee, nurse on duty, and the critical care team. So normally a person will become normal and then they become sick and then they become critically ill. But in pregnancy, they can go from normal to directly being critically ill. So what are primary and secondary service? Physical clinical examination. Whenever you see a woman who is pregnant, do a thorough airway breathing ABCs like airway breathing, circulation, consciousness level. So in the ABCs, it is important to note the respiratory rate. We often miss counting the respiratory rate for 1 full minute because it's usually tedious. And tachypnea is the single most important indicator of critical illness. So if you come across somebody who is having tachypnea, then that means there is definitely something wrong. Tachycardia can be physiological. High blood pressure, low blood pressure can be physiological, but tachypnea is never physiological. And then you should see the oxygen saturation with the saturation monitor. Then look for the use of how they are breathing. Are they using any axillary muscles and things like that. The other important thing is looking at the consciousness level also. Circulation, okay, see the blood pressure, feel for the peripheries, do they feel cold, clammy, and see for the capillary filling time, and then look at the urine output. Urine output and the toe temperature can be expected cardiac output monitors. In the consciousness evaluation, you can use the abbreviation ABCU. A is see if they're alert. B is if they're responding to verbal stimuli. C is are they responding to painful stimulus? So if they're responding to painful stimulus, that means Glasgow Coma Scale GCS is more than 8, or if they're unresponsive, and mark accordingly. Secondary survey is basically your detailed examination of your detailed systemic examination, looking at the respiratory system, sending labs, doing investigations, and things like that. So respiratory cardiovascular evaluation, detailed abdominal evaluation using ultrasound or chest X-ray, and blood samples, and musculoskeletal system evaluation, endocrine hematological evaluation. It also includes the fetal assessment, ultrasound assessment, and also the using the NST evaluation. Coming to scoring systems, there's been a lot of emphasis on using scoring systems in your day-to-day clinical management of the women. There can be two types of scoring systems. One is using just single parameter scoring system. So you take a vital parameter, you can give like a high level and low level to the parameter and see if it is abnormal or normal. And then based upon that, you take a decision. And then there can be aggregate weighted scoring systems. Like you take multiple parameters, give a score to different values, and then add up the scores. And then once score is more than a certain value, you trigger the further evaluation. So single parameter scoring systems are simple, but they're very specific. That means like if there is something abnormal in the single parameter, then usually there is something abnormal. There is very specific. But they are also likely to miss things because the sensitivity is less. Whereas aggregate weighted scoring systems, they are more sensitive, but they require more work because somebody has to take down a lot of parameters, then they have to put it in a chart, add up the scores, and then come up. So this requires more strict, intense nursing care, and sometimes it can cause desensitization to support staff. So they may just write some values and put it off if they feel like everything looks normal. So which is an effective scoring system? So any scoring system, the prerequisites are it should be very clear how it has to be monitored. And then there should be a predefined criteria for what is abnormal and what is normal. Then there should be a protocol that triggers a response. So just recording the vital signs or putting them in a chart is not enough. If something is abnormal, what is the next action that needs to be taken? That needs to be very clear. Who to notify and how to notify them, and then when and how to activate the clinical chain of command. So all these things should be very clear for an effective scoring system to work properly. So we know this is a very old data. So CMS in 2003 to 2005 CMS, that is a confidential inquiry into maternal deaths in the UK, recommended the routine use of MEOS. MEOS is a maternal early obstetric warning system as one of the top 10 recommendations. And the 8th CMS report in 2011 reinforced it that to usage of MEOS in your day-to-day patient care, or use the MEOS chart for every patient who's admitted to the hospital. What is this MEOS chart? It is basically a color-coded chart which monitors the vital signs. So it has 5 simple variables: respiratory rate, temperature, heart rate, systolic and diastolic pressure, and then mental function. It also adds hourly urine output if the woman is catheterized. So they give a value of each vital parameter above a certain level is given red mark, and value of each parameter then above certain level is given yellow mark, and the normal values are given in the white mark. So when you're recording the value, if any of the value falls in the red zone, or if two values fall in the yellow zone, then you should trigger the further chain of examination or early intervention. So this is 89% sensitive and 79% specific. So it's more sensitive than specific. That means there could be some false triggers while using this. But the positive predictive value is 39%, negative predictive value is 98%. That means if everything is fine, it's very unlikely that something is wrong. Limitations of MEOS chart, it is not popularized globally yet, even though it's being introduced almost now 13 to 14 years into the usage. Then it needs training to achieve 100% compliance. So there can be like the nurses can start taking the charts without actually noting the parameters. And so they should know what is the importance of chart and how to properly use it. And then it doesn't recognize whether the patient's condition is improving or further deteriorating. So it's not like something that serially measures something and then tells us how things are from the data. Multi-parameter early warning scoring systems increase workloads of allied staff, and excess false alarm may lead to desensitization. So again, when many of the times you mark something, but then it turns out to be everything's fine, then the nurses think that the score chart doesn't work, and then they become desensitized. And women who died usually have a frankly abnormal sign. So it's also true that if somebody is very sick, then usually they'll have these vital parameters very abnormal. So to simplify the MEOS chart, we need something that we can use easily, and simplicity and specificity is preferred over complexity and sensitivity. So keeping this in mind, the Jill Mapp and their group from US, they proposed something called maternal early warning tool, or MEWT. So here they're basically looking at only a single parameter, and they have assigned below and above scores, and then diastolic blood pressure above certain value, heart rate, respiratory rate, oxygen saturation, and urine output. They have also considered the consciousness levels like maternal agitation, confusion, or unresponsiveness. So basically, if a value is below these levels or above these levels, the nurse has the ability to trigger and call her seniors or a doctor, whoever she's supposed to report to, for further examination and evaluation. Or sometimes if the nurse feels that everything is fine, but still the nurse has a sense that something is going on, she can still trigger and call for further evaluation. So again, this is one of the guidelines which talks about how to create a chain of command, like whom to call, how to manage, and things like that. Some of these have been touched upon by Dr. Chaitanya Baker in his lecture. So overall standards of recognition and immediate care in involves like every time a woman comes into your outpatient clinic or antenatal clinic, you have to have a very high degree of suspicion. Is everything fine with this woman? Why is she here today? Is she falls under high risk or low risk pregnancy? If you are admitting her, what is the reason you are admitting her? Are there any comorbidities present? Is there an agreed treatment plan once she is admitted? What needs to be done? And what needs to be done? What is her treatment plan? And what can go wrong? And what should be done if things go wrong? And then every patient who is admitted to the hospital should be monitored using an early warning chart. The other scoring system is SOPA scoring system, very popular, commonly used in the ICU. It is basically, I know that most of you already know this, but it basically looks at six organ systems. One is respiration, coagulation, liver, cardiovascular system, CNS, and renal system. So it has given scores from 0 to 4, depending upon the different parameters. And then you add up all the scores and then come up with a final score. A score more than 2 is significant, and you have to take further action. So this score, this is a sequential organ failure assessment score. So this is something you can do daily and see whether the patient is improved or not. There's something called quick SOFA criteria also. So this is like instead of using a SOFA score depends upon your lab investigations. Like you need platelet counts, you need to do blood gases, you need to send liver parameters and things like that. So before you do that, you can do a bedside assessment called something called quick SOFA score, where if somebody is having respiratory rate more than 22 per minute or altered mentation, or if the blood pressure less than 100 millimeters of mercury, if two of these three are present, then you can trigger further evaluation. But then this was defined in a non-pregnant patient, and a slight modification has been suggested for pregnant women, and the name is Q SOFA P, because respiratory pregnancy, as it is, increases the respiratory rate physiologically. They have put the respiratory rate to 35 per minute, more than 35 per minute, against systolic pressure less than 85 millimeters of mercury, and any altered mental pressure. So two of these three are present, then you have to go for further evaluation. Other important tool to identify sick mothers is doing a blood gas. So have a very low threshold to do blood gas. If you are unable to do RTA blood gases, or even venous blood gases, it gives us a lot of information about, especially about breast deficit and lactate level. So in one of these studies, basically they looked at, they did ABGs in women, and then they also measured cardiac output. So cardiac output parameters, different cardiac output parameters, and then they did base deficit. So when they noted that when base deficit in the blood gases is more than -8 and lactate levels are more than 2, there is a fall in cardiac output, noting that the organ supply is affected. And also they mentioned that if base deficit is more than -8, it probably predicts fetal acidosis and probably an early marker of impending fetal death or maternal end organ ischemia. So before you see there are changes in the organ parameters, or like increased creatinine or increased liver function, probably this is the first one that goes up. So doing a blood gas and looking at base deficit lactate levels and acidosis levels, so you will have a fair idea that if she's stable or if there's any impending, if she's going in the direction of organ failure. So this is an example. So we had a severe preeclampsia, HELP syndrome mother who came to us in the middle of the night, around 10 o'clock. And her admission ABG, she had very severe acidosis. 7.08 was her pH. Base deficit was -21, and lactate were 1.68. So my -21 base deficit is like very severe thing. And also 7.081 is again very severe acidosis. So she was given IV fluids and she was having a decreased urine output. She was given IV fluids, put on Hudson mark, and then platelet. Luckily for us, her platelet counts were more than 1 lakh, and then we gave spinal and delivered her. We did an immediate cesarean section. So by early morning, her creatinine come down from 1.2 to 1, and the repeat blood gases improved dramatically from 7.08 to 7.38. PCO2 input, and then the base deficit is also improved from -21 to -7. So once you delivered, basically what happened was the kidney started working and the acidosis got corrected. So just within a span of 8 hours, she started her journey towards normalization. So to conclude, have a high degree of suspicion when somebody is getting admitted into the hospital. Detection of clinical deterioration, recognition of illness is very important. So use the MEOS chart and have a multidisciplinary care plan in place. Uh, have a plan to how do you examine her? What is the plan for delivery? And if you need to transfer, where and how you are going to transfer her? And then which level of care she needs to be transferred. Does she need a HDU care or does she need an ICU care? So if you have these things in place, it will be easier for you to go to the next level and initiate a efficient transfer to a higher center. So most of the times what we see is the three causes of maternal mortality or morbidity is usually hypertension, sepsis, and then hemorrhage. And which very often we see that doctors or care providers tend to get confused when there is a presentation of hypertension which is atypical. And instead of just going ahead and stabilizing them and delivering them or giving IV uh, antihypertensives and magnesium sulfate in time, stabilizing, delivering them, they tend to get carried away thinking something very complex is going on. Similarly, sepsis, usually it is the viral pneumonias, the dengue in these season, and then the puerperal sepsis is the most common cause. So being aware of which antibiotics to use, what is the condition, what are the tests that you need to send, and starting the antibiotic, we will go a long way. Thirdly, we all know that hemorrhage is a possibility and it can come it can happen to anyone out of the blue. So it's important for all centers who are delivering a mother to be prepared for handling hemorrhage. So we all again there's a tendency that we assume no, it's not going to happen or I can handle things like that. Ensure that you have a plan in place where to procure blood, how likely she is going to bleed, if she bleeds, who is my secondary help, where am I going to get blood and things like that. You have additional help to get the blood on the right time. So have a definite care pathway in place. So if somebody comes from hypertension, okay, you have triggered the alarm, you have triggered higher level of care. So for hypertension, what are the drugs that you want to give? If it is not coming down, then what are you going to do next? How will you deliver her, or where do you transfer her? Similarly, for sepsis, what are the minimum tests that you would send? How soon you are going to, which antibiotics you would start, and then what are the tests or lactate you would monitor? And then hemorrhage, again, have a hemorrhage protocol in place. Where do you, for which patients you want to reserve the blood, for which patients you want to check the availability, who is going to get the blood if there is any bleeding, and how would you manage, who will be your secondary help. So have these things in place before you treat any patient in critical patient, then it makes your things easier. So to conclude, early identification by adapting scoring systems to local hospital logistics and then implementing successfully is the key. And then appropriate management, right treatment at the right time, and having established care paths will go a long way in improving the outcome. Thank you. Thank you so much.
Thank you so much, Manokant sir, for that informative presentation. Our chairpersons would like to add on something.
Just to say, such a wonderful deliberation by Dr. Manokant. Though they say that pregnancy and labor are normal physiological processes, but the potential for the catastrophic complication is constant and they may develop in the matter of minutes. So the careful monitoring of the patient and sticking to the scoring system is really very valuable. So thank you for guiding us very nicely to find out the sick party end. Thank you very much.
You're welcome.
Yes, Sahai ma'am, please. Sahai ma'am, please unmute yourself.
Sahai ma'am, now
Yes.
I think we've been unmuted. Ma'am, you have been unmuted. सांगितलं ना? घेऊन अशी यायची आहे ना? Now you can just try to talk. Sahai ma'am.
Sorry, something is going wrong. I
Yeah.
wanted
Now we can hear you.
We can hear you, ma'am, now.
Okay, no, I just wanted to say it was an excellent presentation. Okay, thank you so much. Okay.
Yeah,
Thank
thank you
you.
so much, ma'am.
Thank you again, Rashmi and Devyani, for giving us this opportunity. Yeah, very nice presentation, Manukan. Simple and precise. And yeah, we really have to look into it.
We should be thanking you, Manisha, Chaitanya sir, and Manotha. That was really a short notice. But
Thank
then
you.
it was excellent. It was really excellent. Actually, all the topics like we have routinely in our anesthesia CMEs, they were different. The approach was different. So it was wonderful hearing to all those new ideas.
And I must
Yeah.
congratulate both of you that we had almost 80 people who had logged in, much more than
Yes, yes.
that
Actually,
we have in our physical conferences.
Yes,
So
yes.
yeah, that
actually,
was
all the year
the
round, ma'am,
case.
we've had really good attendance just because of the excellent faculties that we had in all our CMEs and webinars.
And topics also.
Yes.
They were different.
And I would
Thank
like
you,
to
Rashmi and
thank.
Devyani, for giving us chance for this thing and wonderful topics and wonderful speakers, really.
Yeah.
Thank you very much.
Thank you, ma'am. Thank you, Sai. Sai madam also, when I called her up, she was little hesitant just because of recent surgery she has undergone. But then I said, it's a webinar. You have to attend from home. She was then more than happy to join. She's still practicing, I must say. She's still practicing the obstetric anesthesia. She drives a car and moves all through the traffic of Nagpur and for all the calls. We look up to you, ma'am. Sai, ma'am. Thank you so much for accepting our request.
I would like to thank all the faculties for such elaborate and practical and vividly explained points in all the deliberations. They were really a food for thought for each of us, because everybody faces those problems in everyday lives, but it's just that there is no way to go and solve those problems. So I think ma'am's talk on that educating for the maternal care is so important and so required. Chaitanya sir, so I would say that even if somebody calls you in the middle of the night and asks you how to set up an HDO, you will be equally good at that hour of the day also. And Manokan sir, it was an excellent way, which was very well simplified and elaborately told how to identify that sick parturient and going ahead for treating those patients. I'm like privileged to have all of you over here for the webinar, and thank you so much. I thank all the chairpersons, Sahai ma'am and Harkari ma'am, who highlighted the real points which were required to be remembered. And as Sahai ma'am said that, yes, we would require revisions of all the things so that we can actually bring it into functioning.
Yeah, review meeting.
Yeah, review meeting. I thank all the delegates also who joined for today's meeting. I could see like Rajurkar sir, Indrani ma'am, Ganbute sir, then Kiran ma'am, and so many, like around 80, 82 people who joined. And I think it was all because of the wonderful presentations that we had. Thank you so much, all of you, for joining. Thank you so much. Over to Kate.
Thank you.
Thank you so much to all the faculties, our respected chairpersons, and the participants. I think this is the end of the webinar now. Thank you so much for participating today and for your precious time. Thank you.
Thank you and good night.
Thank you very much.
you.
Thank you so much.
Thank
Have a
you.
very
Thank you. Bye bye.
Thank you, everyone.
Leave now.